Dear students, I am Dr. Mushfig Orujov from Department of Pathological Anatomy, Azerbaijan Medical University. Now, let me start our lecture. The topic of our lecture is inflammation, a term of inflammare, taken from the Latin term that means to set on fire. Inflammation is a defensive process that a living body initiates against local tissue damage. It takes the form of a complex vascular mesenchymal reaction of blood vessels, certain plasma components, and blood cells, and cellular and structural components of connective tissue. The goals of inflammation are to eliminate the initial cause of cell injury, remove necrotic cells and tissue, and initiate the process of repairs. Some agents they cause the inflammation. There are physical agents, that extreme temperatures, electric shock, radiation, mechanical injuries, etc. Chemical agents, the products of metabolism, acids, alkali, drugs, tissue necrosis, and biological agents, the microorganisms, parasites, immune cells, and immune complexes. The components of the inflammatory process include white blood cells, or the leukocytes, and plasma proteins. They normally present in the blood. The inflammatory reaction's goal is to bring freeze to the size of infection and or the tissue damage. Inflammation is induced by chemical mediators produced by damaged host cells, such as the cytokines and other mediators. Inflammation is normally controlled and self-limiting. The indication of inflammation, we add the suffix itis to the Greek term endings. For example, the inflammation of stomach we call gastritis. Inflammation of kidney we call as nephritis. Inflammation of liver we call as hepatitis. Inflammation of palatine tonsils we call as tonsillitis, and etc. And there are some exceptions. For example, inflammation of lungs we call as pneumonia, suppurative inflammation of luminal organs, empyema, and suppurative inflammation of hair follicles, furuncle, etc. There are 5 cardinal signs of inflammation. The first of these signs offered by Celsius, the well-known Roman Italian scientist. There are heat or the color, redness or rubor, swelling or tumor, and pain or the dolor. And the late cardinal signs of inflammation, loss of function, offered by the well-known German pathologist, the father of the modern pathology, by Professor Rudolf Virchow. And in this picture, we see with you the severe bilateral inflammation and swelling of the legs. And this illustration very well explains the cardinal signs of inflammation. Here we see the local hyperthermia, the color, the rubor, hyperemia, the tumor, tissue swelling, the dolor, the burning pain, and functional impairment, we call the Funktionsstörung. This slide illustrates the 2 clinical presentations of the inflammation. The rubor, another means this is the redness, and tumor, that means the swelling. There are 3 phases of inflammation: alteration, exudation, proliferation. Alteration, it means the damage, that also divided into 2 phases, the degeneration, or another term we call the dystrophy, and necrosis. Exudation, this is the reaction of microcirculation, formation of liquid exudate, migration of leukocytes, and phagocytosis. And proliferation, this is the intrinsic number of the blood cells and tissue cells, such as the macrophages, lymphocytes, and fibroblasts. There are some principles of classification of inflammation. For example, according to the course of inflammation, we can classify acute, subacute, and chronic inflammations. According to the predominant inflammatory phase, we divide two kinds of inflammation, exudative and proliferative. You remember that there are no alterative inflammation here. And according to the etiological factor, there are trivial and specific inflammations. Acute inflammation lasts from several days up to the several weeks, and in the focus of inflammation, there are many neutrophils and intravascular platelet activation. Here prevail the exudative phase of inflammation and rarely observe the proliferative or the productive inflammation in the viral inflammations, for example. Second type of inflammation, subacute inflammation, that lasts from several weeks up to several months. And in the inflammatory area, we can find both the neutrophils, lymphocytes, plasma cells, macrophages, and the exudative productive inflammation prevail here. And chronic inflammation, they last from the few months up to tens of years, that alternating the exacerbations and remissions. In the focus of the inflammation, there are many mononuclear cells, especially the lymphocytes, plasma cells, macrophages, but in case of the exacerbations, neutrophils are added here. This is the productive inflammation, and during the exacerbations and exudative reactions is added. And in the chronic inflammation, presence of fibrosis is essential. This slide illustrates the acute inflammation, acute appendicitis. In the field of the vision, we see with you the abundant inflammatory cell infiltrate that mainly include the neutrophils. So the neutrophils, there are markers of the acute inflammations. And I think you remember the neutrophils from the histology course, that they are differ for the segmented nuclei. Next slide illustrates the microscopic picture of chronic cholecystitis. The lamina propria here is infiltrated by lymphocytes and plasma cells. We can find here some plasma cells here, that they characterized by the eccentrical location of the nuclei and the transparent cytoplasm. Here you see the comparison of the acute and chronic inflammation features. Exudative inflammatory reaction, the response pattern of acute inflammation characterized by exudation of blood components and immigration of blood cells. The acute exudative inflammatory reaction consists of these formal pathogenetic elements. First, the change in microcirculation, second, change in permeability, and third, the leukocyte transmigration. In this illustration, you see the normal microcirculatory pathway, that here you see the arteriole, capillary network, and the venule. Here we see the dilatation of the venule and the leakage of the plasma proteins that they form the edema, expansion of the capillary bed, and the third phase, the immigration of the neutrophils from the blood flow to the extracellular matrix. Change in microcirculation in the first phase, during the 1 second or a minute, the transient arteriolar vasoconstriction. Here, not detectable in every inflammatory reaction. In the second phase, we found the vasodilatation of the arterioles, capillaries, and postcapillary veins. This causes exudation of blood serum that leads to inflammatory tissue swelling with stimulation of the pain nerves. In the third phase, we see the vasodilatation of the capillaries and arterioles and vasoconstriction of the venous. This slows the circulation, elevates filtration pressure, and increases the vascular permeability in the inflamed area. Change in permeability. What the biologic purpose of exudation? First, contaminants are diluted by the protein-rich exudate. Contaminants are neutralized by the rapid introduction of counteractive substances such as antibodies, and contaminants are fixed and damage is controlled. The coagulated fibrin in the tissue demarcates the inflammatory damage and fixes the pathogens. The endothelial damage leading to the vascular permeability. First, the endothelial cell contract. They are not necrosite. Here, the contraction of the actin of cytoskeleton of the endothelial cells of the postcapillary venous under the influence of the inflammation mediators, opening pores in the walls of the capillaries. Here, you see the pores between the endothelial cells. That they result in regulated, moderate fluid exudation. But if the endothelial cells they undergo the necrosis, they results the formation of the holes in the wall of the capillary that results the unregulated excessive fluid exudation. So here you see the endothelial contraction, endothelial swelling, and the endothelial necrosis. Then leukocyte transmigration. The leukocytes traveling into the inflammatory regions, exiting the blood via the vascular wall, must construct a temporary and efficient defensive system. First, the leukocytes. There are three sequences of events that include the leukocyte margination and rolling, leukocyte adhesion, and leukocyte transmigration, or we call the chemotaxis. Here we see the activation of the endothelial cells and the approach of the polymorphonuclear cells or the neutrophils to the endothelial cells, the rolling of these cells, then firm adhesion, the neutrophils to the endothelial cells, and transmigration between the endothelial cells of the neutrophils. And here we have some illustration that show that the leukocytes migration, that here we see the schematic and the intravital microscopy of leukocyte margination. Then in the hematoxylin eosin slide, we do the leukocyte adhesion here, the neutrophil to the endothelial wall, and electron micrograph that show that transmigration of the leukocyte through the endothelial through the capillary wall. The chemical substances known as the mediators, they play a very important role in the development of inflammation. The chemical substances that trigger certain process in an inflammatory reactions we call the inflammatory mediators. Mediators are differentiated according to their origin. The necrosis-derived mediators, another we call the kinins, the cell-derived mediators such as the histamine, serotonin, interleukins, arachidonic acid derivatives, prostaglandins, platelet activating factor, and plasma-derived mediators. Here you see the illustration of this inflammatory mediators, the cell-derived mediators, plasma-derived mediators, and the necrosis-derived mediators. Pathogenesis of exudation phase. Initial short-term microvascular spasm we found here in the exudation phase that followed by a long persistent dilation. Second, the release of the plasma and its protein components, the albumins, globulins, fibrinogen. Third, stasis, diapedesis of leukocytes and red blood cells in the surrounding extracellular tissue elements, the formation of the exudate, and phagocytosis. The purpose of proliferative phase, the last phase of the inflammation, completing of phagocytosis, the final destruction and elimination of the etiologic agents. Second, the elimination of inflammatory focus from healthy tissue and replacement lesion scar tissue. The purpose of the proliferative phase, this is the repair of the damaged tissue. Now let me discuss about the kinds of the inflammations. First, we start about the types or kinds of the exudative inflammation. The exudative inflammations, whose the principal histologic findings include the exudation of blood serum and extravasation of blood cells into the inflamed area. They may be classified as follows according to the principal components of the exudate, such as the serous inflammation, serous exudate inflammation, catarrhal exudative inflammation, fibrinous inflammation, purulent inflammation, hemorrhagic exudative inflammation, and putrefactive exudative inflammation. Serous inflammation is exudative inflammation with exudate of fibrin-free serum. Biologic purpose of the serous inflammation is immediate dilution of the harmful agent at the site of inflammation. The etiologic factors of serous inflammation include the hypersensitivity reactions, bacterial and viral tissue injury, and physical and chemical tissue injury. Here we can differentiate the two kinds of the fluid that they present in the tissues, the exudate and transudate. The exudate is transparent liquid that forms during the congestions. It will be discussed in the hemocirculatory disorders that they consist up to 3% of protein and includes the isolated mesothelial cells, accidental single leukocytes, and erythrocytes. But the serous exudate is the slightly not quite clear liquid that originated from the inflammation that include the 3 to 5% of protein with a small amount of leukocytes, desquamated epithelium, and mesothelial cells. In this slide, you see the erythema and swelling with the sparse leukocyte infiltrate in the serous inflammation. Here you see the illustration of acute laryngeal edema of the larynx. Examples of the serous inflammations: the initial transitory stage preceding other forms of inflammation, inflammation of serous membranes such as the pleura, pericardium, peritoneum, and joints, organ inflammation such as the serous hepatitis, serous nephritis, myocarditis, encephalitis, vesicular skin infections, and serous mucosal inflammations can lead to acute glottal and laryngeal edema with risk of asphyxia. Catarrhal inflammation. This is the exudative inflammation occurring exclusively on the mucous membranes of the respiratory and gastrointestinal tracts and producing the watery exudate of serum and mucus. Subtypes of the catarrhal inflammation: the mucous inflammation that most frequent, serous, purulent, and hemorrhagic. The etiologic factor same with the exudative serous inflammation, the hypersensitivity reactions, bacterial and viral tissue injury, physical and chemical tissue injury. The mucosa and submucosa in the catarrhal inflammation appear reddened and swollen with a slight degree of lymphocytic inflammation. This micrograph demonstrates the acute rhinitis, that the inflammation of the nasal mucosal membrane of the nose. For example, as we said, that acute rhinitis, the common cold, acute catarrhal bronchitis, and enteritis. We must know that complications of a cold include the bacterial soup infection progressing to purulent catarrhal inflammation with the yellowish-green mucus due to an epithelial defect. Another cause of the exudative inflammation is fibrinous inflammation. Is exudate inflammation with exudation of fibrinogen-containing serum that polymerizes to fibrin outside the blood vessels. The biologic purpose of fibrinous inflammation: immediate temporary barrier against additional effects of inflammation. The etiologic factors of fibrinous inflammation include infections, toxic tissue injury from physical trauma, chemical and toxic tissue injury, excretion of toxic metabolites, for example, uremic toxins, and ischemic tissue injury. Here we see the fibrinous exudation in the wall of the blood vessels. There are some types of the fibrinous inflammation, the three types of the fibrinous inflammation: fibrinous parenchymal inflammation, fibrinous serosal inflammation, and fibrinous mucosal inflammation, that also divided into two types: the Kruppe's fibrinous inflammation and diphtheria fibrinous inflammation. Fibrinous parenchymal inflammation is exudative inflammation with exudation of fibrin on the inner surface of the pulmonary parenchyma or the pulmonary alveoli. For example, the lobar pneumonia in the gray hepatization stage. Fibrinous serosal inflammation is exudative fibrinous inflammation of the serous membranes, may occur as a reaction of the serosa to other underlying disorders, serositis, or in the presence of tissue injury occurring in the serosa, such as infection. The morphology of the fibrinous serosal inflammation. Serosa will appear dull where slight amounts of fibrin are present. Massive exudation of serum will produce villous deposits of fibrin, as a fibrinous pericarditis, or we call the hairy heart. Later, the fibrin deposits are absorbed by histiocytes and transformed into scar tissue, creating adhesions between the layers of the serosa. The clinical presentation of the fibrinous inflammation is auscultatory finding include the sounds of pericardial friction resembling crickling leather. Patients report the chest pain and the heart is enlarged. Here we see the gross view of the fibrinous pericarditis, hairy heart, also the fibrinous, the microscopic view of the fibrinous pericarditis, and the fibrinous pleuritis, the microscopy and microscopy of the fibrinous pleuritis. You see here the gross view of the adhesions that forms between the layers of the pericardium during the fibrinous pericarditis. Next type of the exudative inflammation is the exudative fibrinous inflammation is the fibrinous mucosal inflammation. In the fibrinous inflammation, the mucosa, the fibrinous exudation process is usually preceded by superficial necrosis that divided to the Kruppe's type and diphtheria type. The Kruppe's type is the exudate inflammation in which a wide area of fibrinous exudate forms an easily removable pseudomembrane covering the necrosis, which is limited to the mucosal epithelium. Example, you can show the diphtheritic laryngotracheitis. But diphtheria type is the exudative inflammation in which necrosis extending into the submucosa is covered by a wide area of fibrinous exudate in the form of an adhesive pseudomembrane that can only be forcibly removed. For example, in the diphtheritic tonsillitis and pharyngitis, the dysentery, and antibiotic-associated colitis. Next type of the exudative inflammation is purulent inflammation or the suppurative inflammation. It is inflammation with exudate consists primarily of diet neutrophils and cellular debris or the detritus. The biologic purpose of the purulent inflammation is damaged tissue is dissolved along with the pathogen. The pus consists of the phagocytosing neutrophils with cellular debris or the detritus. The etiologic factors are the pyogenic bacteria such as the staphylococci, streptococci. There are some types of the purulent inflammation, the empyema, phlegmon, abscess. The empyema is suppurative inflammation in a body cavity. The empyema usually occurs when a suppurative inflammation of an organ breaks through into the adjacent cavity. For example, the pericardial, peritoneal, and pleural emphysema, gallbladder and appendiceal emphysema, middle ear and nasal sinus emphysema, pyosalpinx pass in the uterine tube, pyoencephalus pass in the cranial cavity, hypopyon the pass in the anterior chamber of the eye. Here you see the gross view, the pleural emphysema, that after the removing of the lung, we see the pus in the thoracic cavity. Other types is phlegmon. Phlegmon is diffuse suppurate inflammation that spreads primarily in loose fibrous connective tissue without sharp demarcation. For example, the muscular phlegmon, phlegmon of the flow of the mouth, mediastinal phlegmon, phlegmon of the walls of hollow organs such as the phlegmon in cholecystitis, appendicitis, erysipelas, inflammation in the connective tissue of the skin, usually caused by beta hemolytic streptococci, involving a map-like pattern of erythema and swelling. Abscess is an accumulation of pus with tissue distraction and cavity formation. For example, the pulmonary abscesses, cerebral abscesses, kidney abscesses, liver abscesses, furuncles are the abscess-forming inflammations of the hair follicle, usually following staphylococcal infections. There are three layers of the abscess capsule. First, the central location, the pus, that they covered by granulation by the pyogenic membrane, that finally they covered by the granulation tissue of the repair. Next type of the exudative inflammation is hemorrhagic inflammation. Hemorrhagic inflammation is exudative inflammation involving microvascular injury with massive microvascular bleeding, producing an exudate with a high erythrocyte content. Biologic purpose is exudative inflammation due to the severe vascular injury. The inflamed area is usually necrotic and filled with the blood. Etiologic factors of hemorrhagic inflammation are bacterial exotoxins and endotoxins, viral cytopathic effect on endothelium, proteolytic tissue destruction, and cytotoxic injury in hypersensitivity type 3. Examples of hemorrhagic inflammation include the plague, influenza pneumonia, disorders associated with hemorrhagic Escherichia coli, anthrax, viral hemorrhagic fever, acute pancreatitis. This slide illustrates the examples of the hemorrhagic inflammation. This is the intravital microscopy of hemorrhagic inflammation, then hemorrhagic inflammation of the adrenal cortex, the plaque lymphadenitis, and hemorrhagic pneumonia. Here we see the hemorrhagic urocystitis, the hemorrhagic inflammation of the urinary bladder infected by the BK virus, and the hemorrhagic inflammation of the pancreas, known as the hemorrhagic pancreatitis. And final type of the exudative inflammation is putrefactive inflammation. It is the inflammation with putrid smell. Etiologic factors are the putrefactive anaerobic bacteria, Clostridium perfringens. Morphology is massive necrosis without demarcation. And clinical course is severe intoxication, sepsis, and death of the patients. There are favorable and unfavorable outcomes of acute inflammation. The favorable inflammation include the absorption, tissue repair, and organization, or the scar formation. And unfavorable is the acute organ insufficiency, abscess formation, and persistence of inflammation, and transfer to the chronic inflammation. This slide very well explains the outcomes of the inflammation. Here you will see the acute inflammation that results with the healing with the fibrosis formation, then healing with the pus formation that we call the abscess, resolution, completely resolution of the process, and unfavorable to the chronic, the transform to the chronic inflammation that also results to the formation of the scar tissue, that here we see the loss of function. Now let us discuss about the chronic inflammation. The features of chronic inflammation. Inflammation, it means that they durate a long time. The components of the chronic inflammation are the lymphocytes, plasma cells, macrophages. In the chronic inflammation, we found the tissue destruction by inflammatory cells and repair with fibrosis and angiogenesis, new vessel formation. Causes of chronic inflammation may be persistent injury or infection, for example, ulcer, tuberculosis, prolonged exposure to toxic agents, for example, pulmonary silicosis, autoimmune disease, self-perpetuated immune reaction that results in tissue damage and inflammation, such as the rheumatoid arthritis, systemic lupus erythematosus, multiple sclerosis. Here you see the diseases with chronic inflammation. There are 4 types of chronic inflammation. First, interstitial inflammation, chronic inflammation with polyp and pointed condyloma formation, granulomatous inflammation, and chronic inflammation around the foreign bodies. Interstitial proliferative or productive inflammation. The lympholeukocytic or lymphohistocytic infiltration develops in the stroma of organs along the vessels, nerves, and connective tissue. The inflammatory polyps are developed in the mucosa during the long-time chronic inflammation. Here you see the gross view, macroscopy of the inflammatory polyp and the histologic features of the inflammatory polyp in the mucosa. Granulomatous inflammation is the accumulation of inflammatory cells around the necrotic focus and appearance the nodular inflammatory area. The inflammatory area is called the granuloma. The disease accompanied with granulomatous inflammation are known as granulomatous diseases. Granuloma is a microscopic aggregation of macrophages that are transformed into epithelium-like cells or epithelioid cells surrounded by a collar of mononuclear leukocytes, principally lymphocytes, and occasionally plasma cells. Epithelioid cells fuse to form giant cells containing 20 or more nuclei. The nuclei arrange either peripherally, Lancaster giant cells, or haphazardly, we call the foreign body type giant cell. These giant cells can be found either at the periphery or the center of granuloma. There are 3 phases of granuloma organization. First, accumulation young mononuclear cells, their transformation into macrophages, and formation of mature granulomas. Here you see the composition of the granuloma that include the central necrosis that surround the cells that include epithelial cells and the multinucleated giant cells. This slide illustrates the tuberculoma or the granuloma of the tuberculosis, that we see the central location of the caseous necrosis or the dry necrosis that surrounded with the inflammatory cells, and here well prominent the Langhans cells. And here you see the high power of the Langhans cells. Common features of specific inflammations. Each disease possesses their own causative agent, formation of necrotic foci, development of granulomatous inflammations and characteristic granulomas, periodic immune change, and chronic wave-like course. We'll discuss about some kinds of the specific inflammations. Let me start from the tuberculosis. The causative agents are the Mycobacteria tuberculosis. They stand with the Zil-Nielsen method. There are 3 types of the tuberculosis: primary, hematogenic, and secondary. Detailing about the disease as tuberculosis we'll discuss with you in the next term. Here we see the also the schematic figure of tuberculous granuloma. We'll discuss in our previous slides about this one, that centrally located the caseous necrosis with the surrounded inflammatory cells that include the epithelial cells, the macrophages, and multinucleated giant cells or the Langhans cells. Also, the histologic view of the tuberculous granuloma, the high magnification of the tuberculoma, very interesting says that here we can classify differentiate the two kinds of the multinucleated cells. With the immature, we call the Muller type, and mature Langhans type giant multinucleated cells. Next type of the specific granulomatous inflammation is syphilis, that they caused by the Treponema pallidum. There are two kinds of the syphilis, the acquired and congenital syphilis. Acquired syphilis also acquired and congenital syphilis also divide in some types. The congenital syphilis divide the syphilis of immature fetus, early congenital syphilis, and later congenital syphilis, and acquired to the primary period, secondary period, and tertiary period. The primary syphilis is the stage of the organism's entry into the body. The first signs of infection are not always noticed. After an incubation period ranging from 10 to 90 days, the patient develops the chancre, which is a small blister-like sore about 0.5 millimeter inch or the 30 millimeter in size. The chancres are not painful and disappear in 3 to 6 weeks even without treatment. And here forms the primary severity complex that include the firm chancre, lymphangitis, and lymphadenitis. Secondary syphilis, the syphilis enters the secondary stage between 6 to 8 weeks and 6 months after the infection begins. Chancres may still be present but are usually healing. There are skin rashes and ulcers in the mucous membranes called as syphilis. The skin rash may mimic a number of other skin disorders such as drug reactions, rubella, ringworm, mononucleosis, and pityriasis rosea. The skin rash, oral and genital ulcers, and condylomata later are all highly infections. And tertiary syphilis. Untreated syphilis progressed to a third or tertiary stage in about 35–40% of patients. Some patients develop so-called benign late syphilis, which begins between 3 and 10 years after infection and is characterized by the development of gummas. Gummas are rubbery tumor-like growth that are most likely to involve the skin or long bones, but may also develop in the eyes, mucous membranes, throat, liver, and stomach lining. This period is developed as a proliferative granulomatous inflammation and chronic proliferative interstitial inflammation. In this slide, we see with you the syphilitic gumma or the granuloma, syphilitic granuloma, with the central located necrosis, glue-like necrosis that is surrounded with the inflammatory cells, such as the lymphocytes, plasma cells, fibroblasts, macrophages, histiocytes, epithelial cells, and development of the vascular connective tissue we see here. This slide illustrates the tuberculous granuloma versus syphilitic gumma. In the tuberculous granuloma, there is caseous dry necrosis, but the syphilitic gumma is glue-like wet necrosis. Blood necrosis, blood vessels, they present in the syphilitic gumma, absent in the tuberculous granuloma. The elements of the connective tissue fibers, collagen fibers, more in the syphilitic gumma, but reticulum fibers prevail in the tuberculous gumma. Diameter. The syphilitic gummas so large that they can reach to some centimeters, but tuberculous granulomas, they were small. The diameter varies between 2 and 5 millimeter, and most common cells in the tuberculomas, epithelial cells with the giant lung cancers, but in the syphilis absent the lung cancers. There are many fibroblasts and histiocytes. Some types of the syphilis is neurosyphilis, or the syphilis of the brain, with the some forms, the gumose form, or the type simple form, neurovascular form, paralytic form, and spinal tabes, the tabes dorsalis or spinal paresis, the damage or atrophy of spinal cord, progressive paresis, and general cachexia. Now let me discuss about the congenital syphilis. As we said, there are three types, three pairs of the congenital syphilis. First off, the syphilis of immature or stillborn fetus, infected in the first periods of pregnancy. Second, early congenital syphilis. This is the subset of cases of congenital syphilis. Newborns may be asymptomatic and are only identified on routine prenatal screening. If not identified and treated, these newborns develop poor feeding and rhinorrhea. By definition, early congenital syphilis occur in children between 0 and 2 years old. After, they can develop late congenital syphilis. Symptomatic newborns, if not stillborn, are born premature with hepatosplenomegaly, skeletal abnormalities, pneumonia, and a bull skin disease known as pemphigus syphiliticus. Late congenital syphilis, it occurs in children at or greater than 2 years of age who acquired the infection transplacentally. Symptoms include the blunted upper incisor teeth known as the Hutchinson's teeth, inflammation of the cornea known as the interstitial keratitis, deafness from auditory nerve disease, frontal bossing, the prominence of the brow ridge, saddle nose, hard palate defect, swollen knees, severe shins, short maxilla, and protruding mandible. In this slide, you see the interstitial keratitis, teeth abnormalities, and the deafness of the patients. Next disease, the specific inflammation, is leprosy or Hansen disease, that they caused by the Mycobacterium lepra. In this disease, morphologically present the leprosy granuloma or lepromas. That structure include the central necrosis with the peripheral macrophages, lymphocytes, plasma cells, and Virchow cells. There are three types of the leprosy: lepromatous leprosy, tuberculous leprosy, and borderline leprosy. Lepromatous leprosy includes symmetric skin thickness and nodules. Damage to the nervous system comes from widespread invasion of the mycobacteria into Schwann cells and into endoneural and perineural macrophages. Tuberculous leprosy, the patients have dry, scaly skin lesions that lack sensation. They often have large, asymmetric peripheral nerve involvement. In this slide, you see the leproma, the granuloma of leprosy. Next disease-specific inflammation is rhinoscleroma. This is the chronic granulomatous disease of the respiratory tract, the nose, larynx, trachea, and bronchi. Causative agent is Klebsiella rhinoscleromatis. Occur at any age in either sex, most common in middle-aged females, in Central and Southeastern Europe, North Africa, Indian subcontinent, Indonesia, and South America. The rhinoscleroma, this histology view of the rhinoscleroma. In the tissues, we can find the Miculid cells and the Russell bodies. This slide shows the morphological markers of specific granulomas, the summary of our previous lectures that include the tuberculosis, syphilis, leprosy, rhinoscleroma, and glanders. And important points. No the 5 cardinal signs of inflammation, now the main features of acute versus chronic inflammation and the predominant cell types in each, now some clinical examples of acute and chronic inflammation, now the stage of immune cell immigration from the blood vessels, understand the basics of immune cell activation and chemical mediators. Thank you very much.